Nice to meet you all. Thank you for tuning in for this. I'm Dr. Guerrero, and I'll be talking about common ailments of the hand, wrist, and elbow. I apologize for any background noise. I was going to do this at my office, but our internet was a little spotty, so doing it at home, so there might be some noise from the dogs or kids in the background. I apologize in advance. So quick kind of about me. My background, I grew up around here locally in San Juan Capistrano. I went to St. Margaret's High School for basically when I started school through high school. Went to Lehigh University in Bethlehem, Pennsylvania to play lacrosse there. Otherwise, you might wonder why a California kid would go to the bitter, cold Northeast. But then went to Tulane in New Orleans for medical school, Duke University for residency. And you can see on the right there in kind of the middle right, that's some of my mentors at Duke performing a hand transplant, which we won't get into that kind of complexity today. But some of my mentors there, Mark Richard, David Roosh, Suhail Matani, some kind of giants in hand surgery, and some people that taught me a lot of what I know about. And then after that, I did a hand and upper extremity fellowship at Ortho Carolina. You can see us down there, myself, a couple of the attendings, working on an arm and a leg, I think, for a nerve autograft reconstruction. Once again, some complex things. The things I'm talking about today won't require 6 different surgeons like that one, and won't be of that complexity, but they're important, and we'll, if any of y'all have them, we'll get you feeling better about them. But that's kind of my journey. And then joined a community orthopedic medical group here in Mission Viejo recently, a few months ago. And I meant to already before we kind of get started. I just wanted to thank Chelsea for putting this on. We gave this talk once before, and I think it was well received. And now we're giving it one more time and recording it online. So thank you, Chelsea. So starting in the finger. One of the more common conditions we see is trigger finger, also known as stenosing tenosynovitis. And basically this usually presents with pain localized to the A1 pulley. So kind of throughout the hand, just before you get to the finger. Other symptoms include kind of catching, clicking, locking, pain, and tenderness. And what happens is basically both, for whatever reason, the tendon kind of tends to rub on that pulley. Those pulleys that you see throughout the finger here are intended to kind of hold that tendon down to the bone. And for whatever reason, in some percentage of patients, this being really, really quite common, you get a nodule on the tendon, and then you get some overgrowth of that pulley as well, and it starts to kind of catch and lock. And you can see on that bottom picture on the left how if that tendon gets stuck there, how your finger gets stuck down like that, and often requires the other finger to release it. Risk factors for this are diabetes and thyroid disease, but a lot of people get it that don't have either of those, and a real common condition that can be pretty bothersome to people. The good thing about this condition is it's something that can be often managed and treated successfully without surgery. Usually the first step in management when I see people is a steroid injection, and the reason is because they work really well for this. Basically, that first injection, about 2/3 of the time, that'll take care of it and won't need any further treatment. If you're in the unlucky third, about half the time, the second injection will make it feel better enough that it doesn't require any further treatment. If you're in the luck, so probably about 80% of the time we can get things feeling better to the point that people are satisfied with it without surgery. If you're in the unlucky 20%, that it comes back, and more commonly in folks with diabetes, the injections just aren't quite as successful. But like I said, this is common enough that 20% that don't get better with the 2 injections is still a decent number of people. So this A1 pulley release is the surgery that we do for this. Fortunately, it can be done wide awake under local anesthesia. So kind of taking away the majority of those anesthesia risks. just a real small incision. Like you can see there, it usually requires about 2 stitches after, and basically just cutting that A1 pulley. And you have the other pulleys throughout your finger. So kind of like cutting a loop on your pants, like a belt loop. You have the other belt loops holding your belt up, so it still functions well. It doesn't really have any loss of function to your finger. The recovery on this one's pretty quick. Dressing for 3 days, then change to a Band-Aid, allowing you're allowed to move your finger the whole time. Stitches come out around 2 weeks, and then once the incision's healed up, around 2 to 3 weeks, no restriction. So pretty quick recovery, and people tend to do real well with it. But a lot of people can be treated without surgery, fortunately. Finger arthritis, this comes in many varieties, kind of throughout the hand, and through the different knuckles. Symptoms include pain, deformity, swelling. You can see the Heberdens and Bouchard's nodes that you can get for DIP, for the different knuckle arthritis that you can get, and often gets loss of motion in clinic. These are things we evaluate with examination and x-rays. In treatment, a lot of these, sometimes they're not very painful and we can observe them. People just want to know what's going on with their finger, and the x-rays can kind of confirm that. Other treatments, anti-inflammatory and possibly therapy. Anti-inflammatory if the pain is mild, therapy if it's a motion issue. After that, we can try injections on these, a steroid injection, which can improve the symptoms for a while. And then if these do need surgery, there are kind of 2 main categories. One being a fusion, where basically, like this picture on the bottom left here, there are different constructs we can use, but basically getting those 2 bones to heal together in a functional position, which really well takes care of the pain. But you do sacrifice a little motion a lot of the time, and we'll most commonly do that either like in the distal, the DIP joint, the one that's way out here, where that motion isn't as important. Losing it, you just kind of have that instead of that. So it's common there. Also common if people have already lost a lot of their motion and say they only have about 20 degrees of motion anyways. That's not a whole lot to give up for pain relief. So those are kind of the main times we think of it. Also with your index finger, just because those knuckles see so much force with pinch that the arthroplasties the joint replacements don't tend to do as well. Joint replacement can be an option when folks have maintained motion and minimal deformity. They just have painful arthritis. Like I said, usually not in the index finger. And these, you do preserve that motion, but they have a little higher complication rate and revision surgery rate than the index finger. Than the fusion. So that's for folks with arthritis who have failed every other kind of conservative management, that's a conversation between those two to be had in clinic, but both are kind of viable options to improve pain control for knuckle arthritis. This is kind of a consequence of that DIP, or kind of distal knuckle arthritis, called a digital mucus cyst. And oftentimes the arthritis itself isn't painful, but they'll have this kind of painful cyst that gets irritated when it gets bumped on things. And basically what happens in these it's a type of a ganglion cyst, which happens all over, that we'll talk about elsewhere. But basically that joint capsule that keeps the joint fluid in gets weakened at a point, and then the joint fluid basically balloons through that point. It's that dorsal osteophyte, so the big bone spur on the back of the finger that you can see in that bottom picture, that usually weakens the osteophyte. That weakens the capsule in the case of these digital mucus cysts. So these are something that can basically diagnose without x-rays, but we do get x-rays just to take a look at that osteophyte. And then options for this are kind of to observe it. It's that mass is not malignant. It's not a cancer. It just is bothersome to a lot of people, and it can cause kind of, changes in the nail and things like that, but it isn't gonna kill you. But for folks that it is painful for, we consider either aspiration, so basically popping that balloon that's coming from your joint, which that's an option, but about 80% of the time it comes back after, and there's a small risk of infection. So plus or minus on that, or more commonly, we'll just surgically remove the cyst, which gets rid of it for good, and removing that bone spur, which gets rid of the cyst for good about 90% of the time. And same thing, that's another surgery that can be done wide awake under local anesthesia. And, no anesthesia risk, kind of similarly, change your dressing to a Band-Aid after 3 days, no restrictions after a couple of weeks. Carpal tunnel is something that you all probably heard of. One of the real common causes of kind of burning and tingling, discomfort, numbness, and then as it gets worse, it can cause kind of weakness as well. This, and basically what it is the median nerve being pinched right at the wrist there. I show you the risk factors there, but it can happen to anybody, and is a really common condition. People will notice pain and burning, tingly sensations in their thumb, index, and long fingers usually, because that's kind of the fingers and half of the ring finger that median nerve provides sensation to. It's most commonly present and most notable at night for two reasons. That nerve goes through a small canal at your wrist with your flexor tendons to your fingers. And it's just kind of a defined amount of space. And we all swell a little bit more at night. So that nerve has even less, that's already tight in there, has even less space once you swell a little bit. And then we all tend to kind of curl up in the fetal position at night. And that puts even more stress and more pressure on that nerve. So burning, tingly discomfort at night, but also sometimes folks will get it when they're driving, when there's pressure there, typing, things like that. So this is something that can be diagnosed just on history and physical examination. Usually get a nerve study and an EMG just to confirm the diagnosis, as well as to show the severity of it. And that has some kind of implications in treatment later. But also, a pinched nerve in your neck can also produce similar symptoms, and we want to make sure that that's the only place that the nerve is being pinched. So that's helpful in that way. And an ultrasound is kind of a newer study for this, but its use is still being kind of defined. The nerve study is kind of the gold standard still. So treatment, the milder cases where it hasn't started to kind of cause you to lose that muscle in your thumb and not causing a whole lot of numbness, and especially if folks are just having nighttime symptoms, we'll usually start with bracing. And that basically keeps you from flexing that wrist down and pinching that nerve worse. If that alone isn't getting it, or getting it done, or if symptoms are worse, then we get that nerve study, which if the symptoms are mild, then if the nerve study kind of categorizes it as mild, we will often consider a steroid injection, because in mild carpal tunnel, a steroid injection will still be effective at a year after the injection, about 80% of the time, versus if it's moderate or severe, that number drops to about 20% of the time. So if it's moderate or severe, that's when we start to kind of consider surgery more seriously. And surgery, once again, I do these two ways. There are two different options for how to treat this. One being kind of the mini open through kind of a small 2-3 centimeter incision that you see on the top right, or endoscopic, which uses a kind of smaller incision in the wrist, and that I'll show you on the other page, and cuts that ligament to open up the carpal tunnel endoscopically. And both are great surgeries. People do really well, but they just kind of have different risks and benefits to each of them. The nice thing about the mini open through that little small incision is that it can be done without anesthesia. So wide awake under local anesthesia, taking away those kind of anesthesia risks. And you have really good visualization. You're kind of looking at everything. Questionably, some of the older studies would suggest that there is a higher risk of nerve injury with endoscopic. On more recent studies, that hasn't really continued to be the case, but there's still some concern over that. But I think with newer techniques and methods, I believe recent studies have shown them to be about equally safe. The nice thing about the endoscopic carpal tunnel, it has that smaller incision in the wrist that you can see on the bottom right there, you're not cutting through any tissue on your palm there. Some people might say it's a more cosmetic scar, but both heal really nicely. There are some studies that say that there's a quicker return to work with endoscopic carpal tunnel, and questionably less pillar pain, that pain in the palm that for some people can last for a couple months after the carpal tunnel surgery, but often people don't even have it for that long either way. And you can see on that bottom left, that's basically what you see in that endoscopic carpal tunnel. You're looking right up through that camera at the ligament, and you kind of cut it through a blade in the camera that you look directly at. With both surgeries, I think both are great surgeries. It's just a matter of preference. If somebody wants to avoid anesthesia, they'll probably go for the mini open one. If somebody's, worried about the scar or worried about, if they like, a great indication for doing endoscopics is either that they're getting both sides at the same time, and you want to consider, which I don't do a lot because I like to have patients have one good hand during recovery. But if they have some reason for that, or if they use a walker a lot and have to put pressure on that palm immediately, those are some reasons to do endoscopic. But usually just a conversation I'll have with people in clinic and see what their preference are. But both work really well. Both you have your dressing on for 3 days, then change to a Band-Aid, stitches out at 2 weeks, and no restrictions about a week after that. Cubital tunnel is kind of the carpal tunnel of the elbow, and that's that. The symptoms are similar, but basically that's where you get kind of that funny bone type feeling, because that's that ulnar nerve, also kind of called your funny bone, being pinched at your elbow there. Same type of examination and kind of nerve studies done in clinic. Similarly happens at night, because you flex your elbow up at night when you're kind of in that fetal position. And similarly, that along with your nighttime swelling puts more pressure on the nerve. And that causes burning and tingling in that small finger and half of the ring finger. And then as it gets worse, it can cause numbness there, or as well as this atrophy in the intrinsic muscles of the hand. Treatment can start with bracing, and that basically, those braces just try to keep you from flexing that elbow up at night to put the less pressure on the nerve. And this one is, the injections haven't proven to be as useful for cubital tunnel syndrome and are not quite as safe. So this is one of the few things that it's kind of, if that bracing doesn't work and you have substantial cubital tunnel syndrome, it's a surgery. But you can see kind of the incision is about 3 centimeters long or so. And, similarly to the other surgeries, pretty quick recovery, dressing for 3 days, change to a Band-Aid, stitches out at 2 weeks, and then no restrictions after that. Dupuytren's disease is also called the Vikings disease because it's common in especially men, but folks of Northern European ancestry. And basically what this is people who have this are predisposed, their genetics kind of predispose them to turning normal bands of tissue into kind of scar-like cords. And like I said, this happens mostly in white or European males. This is something that, we don't need x-rays. It's just something that you look at it, and if you've seen a lot of it, you know what it is. This also can occur in the feet, and then in men it can also occur, and that's called Lederhosen's disease. And in men it can also occur in the penis and cause curvature there, called Peyronie's disease. But the hand is the most common, followed by the feet. Treatment. So a lot of times people will come in thinking that this is a mass or a cancer or something like that. And as long as there's no contracture of the finger, drawing that finger down, this is something that can just be observed and nothing really needs to be done for it. Often I'll just reassure those folks in clinic that it's, just something to watch for. This is something that when it needs treatment is when you can't put your hand flat on a table. And we call that the tabletop test. If that finger is stuck down so much that you can't do that, that's when we start to think about treatment. And there are 3 main treatments for this. Sometimes if it's just painful, but without a contracture, I'll do a little steroid injection there. But if it's actually causing a contracture, the 3 treatments are needle aponeurotomy, which is basically just cutting up the cord with a needle, and that's done just kind of wide awake with local anesthesia. A Xiaflex injection, which is an injection of a collagenase that breaks down that specific collagen, that gets injected, and then a couple of days later, the finger gets manipulated and that cord ruptured. The nice thing is that's one that's done, in clinic. And then finally, surgery. And these three have kind of three different recoveries. The nice thing about the needle epineuritis is, after about a couple of days, you're back to doing everything you want to do. At the Xiaflex injection, your hand kind of swells up and it can be painful for a couple weeks. And then surgery, it's a pretty substantial surgery. Like, that's not an uncommon kind of incision for one of these, a longer zigzag incision. They heal up great, and it works really well. But the recovery is probably about a month till you're really, back to full steam pretty much. So different recoveries, but part of it just depends on the cord and how bad your contracture is. The real bad contractures will sometimes need open surgery, especially the ones that are way out in the finger. The ones that are just in the palm and mostly affect this knuckle, those can be a needle and can get you straightened out and back to activity pretty much right away. A little bit longer time to recurrence with the open surgery, because you're actually taking that cord out, versus the others, you're just rupturing it and lengthening it. But all of these, I tell my patients in clinic when they have it, is that we're treating the contracture. Your body, if you have this, your body is still prone to laying down that collagen and making more of this scar. So a lot of times it can be, years and, sometimes 5, 10, 15 years later, but that finger often gets pulled back down. So this often kind of can require some tune-up type things. Thumb CMC arthritis. This goes by a lot of names: basilar thumb arthritis, trapeziometacarpal arthritis, because those are the two bones that are involved. You can see the metacarpal here and trapezium. Those are the two joints, the two bones that are involved that make that joint and that are arthritic, where that is kind of pointing to. This often presents with pain in the base of the thumb, kind of right there where that's pointing to. That picture on the left is called a shoulder sign, and that's part of kind of the deformity associated with this arthritis. This is really common, and people are often have pain, especially with kind of twisting jars, heavy pinch, things like that. Women get this more commonly than men, but it happens really commonly to men and women. Examination, that bottom right is just kind of one of the maneuvers we do in clinic that kind of elicits pain with this and shows that that is what's bothersome. And we'll get x-rays which show that arthritis there. So treatment, we kind of have, similar to everything else, we try to start with as simple a treatment as possible and try to treat things conservatively. And then if things aren't working, we kind of escalate them as needed. So we'll begin with things like bracing. Oral and topical anti-inflammatories and therapy are often good kind of first lines of treatment. And, for folks with mild arthritis, that'll often, be good enough symptomatic relief for them that arthritis isn't bothering them too much anymore. If those aren't working, then the next step is a steroid injection, which you can get in clinic, and I'll usually do under ultrasound guidance, just since it's a small joint. And that often provides people, fairly substantial relief for quite a while. But those injections, similar to elsewhere, can have kind of diminishing relief. So often the first one might last a year, the second one might last 8 months, third one 6 months. And it kind of, once they stop lasting more than about 3 or 4 months, that's when we start to consider surgery. And this is a picture from kind of one of my patients. I actually saw her at kind of 6 week follow-up today, and her incisions healed beautifully. You can hardly see it. I took a picture but didn't have time to put it in the talk because I was running a little late. But basically the surgery is taking out that arthritic bone and then performing a suspension plasty so that this metacarpal bone doesn't just drop down and hit the next bone and cause arthritis there. And the way that there are a bunch of different ways to suspend that bone, and this has been really well studied, and there hasn't been shown any difference in the results between them. So I do kind of a tendon transfer between the tendon that attaches right there, the APL, and right there, the FCR, and kind of do what's called a suture hammock technique, which kind of brings those tendons together to kind of hold up that metacarpal and suspend it so that it doesn't drop down into that next bone. This is a little bit more substantial of a recovery than the other surgeries, just because it does require some immobilization to allow those tissues to heal and some scar to form before you're to full activity. So my post-operative protocol for this is you'd be in a splint for 2 weeks. At 2 weeks after the surgery, I see in clinic, and take those sutures out, and then put you in a removable brace, and you start kind of gentle motion at that time. But you'd be in a removable brace at all times except for when doing the motion, exercises, showering, washing your hands, things like that. At 6 weeks, we begin strengthening, and then after 8 weeks, there are no restrictions. De Quervain's tenosynovitis is pain that happens kind of close to where that thumb arthritis was, but just a little bit more proximal there, and sometimes the two can both happen at the same time. And this is a stenosing tenosynovitis, kind of like the trigger finger, where those tendons are kind of trapped in a small space. Symptoms are pain and swelling right there. This is really common in new mothers. And basically, because when you lift like this with your wrists, and sorry, you can't really see, in neutral, like you're holding a baby, that puts pressure on that's when those tendons are really being used. So new parents or grandparents will often have this kind of irritation there. Treatment can start simply with rest anti-inflammatories or a wrist brace. This is another one similar to the trigger finger, where the injections just do really well and people get a lot better. I had a family friend who just came in with this and one injection, and it basically went away entirely, and they were really pleased with it. So often I'll even give an injection in the first visit, just people tend to be so happy with it, feeling better immediately, versus rest anti-inflammatories bracing can work, but it can take quite a bit longer. And then one of those, once again, if it kind of gets better and then come with the injection, then comes back, usually similar to trigger fingers, if we've done 2 injections and the relief isn't lasting at that point, then I'll do a de Quervain's release, which is just basically taking the roof off the kind of tendon sheath that those tendons live in, as well as a little subsheath within that one of the tendons is in. And I do that wide awake under local anesthesia through 2-3 centimeter incision, similar to some of the other surgeries. The stitches come out in 2 weeks, no restrictions after 3 weeks, kind of Band-Aid after 3 days. So another pretty quick recovery and a really successful surgery if it comes to it. Wrist arthritis, this comes in many different varieties. Often begins as a torn ligament, usually your scapholunate ligament, which is the one that connects these 2 bones, and those bones are usually closer together. That's kind of wide open in that bottom left picture. But that's often how it starts, as a missed scapholunate ligament injury or a scaphoid fracture that doesn't heal all the way. And those kind of lead to predictable patterns of arthritis. This can also happen from distal radius fractures. So when the bigger bone in your wrist is broken into the joint, it can kind of develop arthritis later. So these can all come with pain, swelling, and loss of motion of the wrist. We usually start with examination and x-rays to kind of confirm the diagnosis. Often first line of treatment is to try immobilizing it, because a lot of the times people will have this and anti-inflammatories, because people will have this arthritis for a long time, and then some insult to it will get it to start being uncomfortable for them. And if we can get it back to where they're arthritic but it's not painful anymore, that's a success. If that's not working as that first line of treatment, an injection is often a good option and can buy folks quite a long time of relief. And then finally, there are different surgeries for if those aren't working. And on the right side are a couple of the surgical options. One of them is taking out the bottom row of kind of arthritic bones. It's called a proximal row carpectomy. And then that next set, in the right patient, that next set of bones just kind of rests down nicely on that next one with the cartilage surface on both of them. And the other option, the top right, is a staphoid excision. So taking out the kind of arthritic bone and then getting into longitudinal or capitolunate fusion. So those are staples that basically fuse those two bones together. And then it uses what the kind of good cartilage that's left in your wrist to articulate through that. So you're not working through that arthritic component anymore. But basically, these are, more information than you need to know, but basically just knowing I've had folks come into clinic who have said, people told me that I have wrist arthritis and that there aren't any options for treatment. You just have to live with it. That's not the case. There are options, and often the conservative stuff works, but if not, we do have surgical options that work well. Ganglion cyst, this is kind of similar to that digital mucus cyst that I talked about earlier, where it's a kind of outpouching of the joint fluid. And these are kind of most common on the back of the wrist, like that picture in the top there. They can also happen in the front of the wrist, right there, kind of near your radial artery. But it can come from multiple different joints, like you can see in that middle picture and picture on the bottom right. And it can also come from your tendon sheaths. And these can often be painful. For whatever reason, they're painful sometimes and not painful others. We don't know exactly why. They'll usually fluctuate in size and often are painful, with wrist extension or flexion when they're getting kind of pinched. First line of treatment is just living with it. It's not something similar to the other kind of cysts. It's not something that's cancerous or going to turn into cancer or cause any problems in that way. So if it's not painful, folks will usually just kind of deal with it. For the ones on the back of the wrist, if it's something that we can try aspirating it with the needle, but that only works about 20% of the time. If it's just pain, we can try a wrist injection sometimes, and sometimes that won't get rid of the wrist. The ganglion cyst, but it'll make it a non-painful one. And then finally, surgery to take it out about 90% of the time. That'll take care of this. That'll make the cyst go away for good, because we actually take a little pouch of that capsule out so that it can't just balloon right back up through it again. So about 90% of the time, that'll take care of the cyst for good. And that's a pretty quick recovery once again. Lateral epicondylitis, this is tennis elbow. So in the kind of outside of the elbow. This is really, really common, not just in tennis players. And basically what happens is little small tears of that extensor origin that kind of extends your wrist like that. Symptoms are pain with activity and often with lifting, especially if you lift something with your palm down. That kind of causes aggravation there. This often happens in laborers, folks who do a lot of heavy lifting, people who play tennis or other racket sports. This is usually pretty evident on examination, but we'll usually get x-rays just to make sure that there's no arthritis as well. Treatment, the good thing about this is something that can be treated non-operatively successfully greater than 90% of the time. The bad thing about it is that can take several months or even a year sometimes. So therapy is a really good first line of treatment, a lot of stretching like that picture there. And then once the inflammation goes down, they'll start to work on strengthening more. Different braces can be effective, either a counterforce brace, the one that's a strap, and that's to kind of get the muscle to pull through that strap rather than up higher where it's inflamed. Also, wrist brace can be effective in different circumstances. Activity modification, trying to avoid lifting things with your palm down. That's and then anti-inflammatories, that's kind of the first line of treatment usually, or kind of all those things. And if that's not getting better, that's when we start to consider either an injection or surgery. Now, steroid injections haven't been shown to be as effective at curing this. They give you a holiday from the symptoms. It usually will feel better for about 3 months. But they've done studies that compared therapy steroid injection or nothing, and looked at the long-term results. And the folks who do therapy do the best. The folks who get the injection do the best initially, and then actually end up doing kind of the worst. And then finally, those who do nothing are kind of in the middle. Another option for this is called a PRP injection. Not something that I kind of say that for a last resort before surgery, because it is usually a cash item that insurances won't pay for, and it often comes out of pocket for folks, and it can be relatively expensive. I think they cost at our clinic like $800, but some places they'll charge you like thousands. And basically, that spins down your cells to the platelet-rich plasma, which has some kind of healing potential, and that's injected into the injured area. And this is one of the few, and this will get pushed by a lot of different providers for different reasons. Often, because of its price, and that it can be profitable for those people who charge a lot for it. But this is one of the few indications where it's actually shown quite a bit of success. Especially I like to use it as a last option before surgery. Used that way, about 2/3 of the time people can avoid surgery with it. So I'll offer it as an option if it gets to that point, but most people get better before it ever gets to that point. Medial epicondylitis is kind of the other version on the inside of the elbow, and that's those wrist flexor muscles. It's called golfer's elbow, but happens in a lot of people who don't golf. Similar symptoms, just on the other side of the elbow. Treatment is very much the same: therapy, bracing, anti-inflammatories, activity modification, trying to avoid lifting with your palm up. Injections we don't do as commonly here, but can be done. But usually, this one even more so than the lateral side, people get better without surgery, and it's rare to require surgery. Elbow arthritis. This often happens after an injury, but can also happen just from wear and tear. It'll come with pain, stiffness, impingement, which is kind of pain and catching at that end of range of motion, whether it's flexion or extension. And sometimes you'll break loose a little piece of bone spur there that can cause kind of mechanical symptoms like catching and locking. This is most common in males who are heavy laborers or weightlifters, folks with rheumatoid arthritis or having a previous injury. X-rays and an exam will give you your diagnosis here. And treatment, a lot of this depends on severity. A lot of these are treated non-surgically with bracing, activity modification, anti-inflammatories, physical therapy, if motion's the issue, steroid injections. And these are ones that often don't require surgery, but if surgery is required, debriding, getting rid of those bone spurs and releasing the capsule is a really effective procedure, either arthroscopically through little cameras or by a kind of an open surgery and that just depends on kind of how you present and what the arthritis looks like, which you do. But both do real well, especially if the main issue is a lack of motion and pain at the end of range of motion. If you start to have pain within the range of motion, then that surgery becomes a little less effective. But the other option for arthritis, for real bad arthritis with pain in mid-range of motion, is an elbow replacement, which is something that we try to avoid kind of at all costs because it comes with lifetime restrictions. There's a very high complication and revision surgery rate, even if done very well. So that's something that we'll generally reserve for folks who are either lower demand, so who don't do much heavy work or lifting or activity with that arm, or with folks with just terrible arthritis and not much of another option. So take-home points. I know that was a long talk with a lot of kind of medical details, so thanks for sticking with me. But the take-home points is there are a lot of effective treatment options for these problems that you don't need to just live with it. I think sometimes hand surgery, for whatever reason, gets a bad rap because there are some hand surgeries that are kind of relatively easy fix, and most of these are. There are some that are more challenging problems that you have to really manage expectations. But I think if you're having trouble with any of these types of things or anything else in the hand or upper extremity, worth at least getting checked out, seeing what your options are. We usually do our best to go with conservative treatment without surgery and try to get you feeling better that way. And then if those aren't working, we will kind of lay out the surgical options and what the recovery and risks and benefits and things like that look like. But a lot of these surgeries, especially in the kind of hand, fingers, and wrist, have a pretty quick recovery, quicker than you might expect. And finally, I also treat, I'm happy to see you for basically any orthopedic problem, but I also treat a lot of traumatic injuries and shoulder problems. This was just, just focused down the talk, so I wasn't talking all night. I'm in clinic Monday, Wednesday, Friday, so I can always fit people in either same day or next business day. And that's my coordinator's schedule there. That we've had some trouble with kind of issues with our main line for calling, but Lydia is fantastic. And if you call her, she'll be the quickest way to get you an appointment. So thank you all very much for your time. This is my family. That's kind of why who it's all for and what I do it for. And I'll look forward to kind of fielding some questions and then maybe meeting some of you at some point. Thanks again for your time. And thanks, Chelsea, for putting this on.